topic which was assigned to me is the community mental health and well-being in India. So this is the topic which I have planned, and here we are two communities, teacher and students. So let us pray about our community. Om Sahana Bhavatu Sahano Bhunaktu Sahaviryam Karvavahai Tejasvina Vadhitamastu Ma Vidyusavahai Om Shanti Shanti Shanti. इसका अर्थ यह है कि हम सबकी ईश्वर साथ साथ रक्षा करें। हम जो लोग सीखें, जो पढ़ें, उस विद्या के फल का साथ साथ हमें भोग कराएं। हम जो पढ़ रहे हैं, जो पढ़ना चाहते हैं, उस विद्या की प्राप्ति का सामर्थ्य हमें प्रदान करें, और जो भी हम पढ़ें हमारा पढ़ा हुआ तेजस्वी हो और हम एक दूसरे से द्वेष न करें। तो this is the key point of the community mental health, because if there is hatred, if there is jealousness, if there is feeling for anything envious to the other people, our mental health got disrupted in near future. Before going to the main topic, I want to read disclaimer. This presentation is made for academic purpose, not for any kind of commercial activity. I believe that the knowledge that I am going to share with you is not the final truth. It is an attempt to tell as much as I can understand by studying. You are free to agree or disagree with me. If you wish, you may develop your own understanding by this of your studying the reference text on which I am speaking, or you may study other standard texts for your enlightenment. Outline of my talk is what is the mental health and well-being, what is the community mental health and well-being, and what are the current status, promotion of mental health and well-being, and challenges and future perspective with respect of the Indian population about the community mental health. If we see the definition of the health, which was given by the WHO in 1998, this is the health is a dynamic state of complete physical, mental, spiritual, and social well-being, and not merely absence of disease or infirmity. Whereas in Indian context, in Ayurveda, it was given that swasmin tishtati iti sastha, स्वस्थ जो अपने आप में सुख स्वरूप आत्मा में स्थित हो वही स्वस्थ कहलाता है। सुसूत्र संहिता में जो डेफिनेशन दी गई वो कहा गया समदोष समाग्निश्च समधातु मलक्रिया प्रसन्नात्म इंद्रिय मना स्वस्थ इत्यभिधेयते, जिसके तीनों दोष वात पित्त कफ और जिसकी जठराग्नि सम हो, जिसकी धातुओं रक्त रस मांस मेद अस्थि मज्जा शुक्र की क्रिया सम हो, जिसकी आत्मा इंद्रियां और मन प्रसन्न हो, वह स्वस्थ कहलाता है। और पद्म पुराण में कहा गया बुद्धि स्वास्थ्यम मन स्वास्थ्यम स्वास्थ्यमेन्द्रियकम, तथा जिसकी बुद्धि मन और सभी इंद्रियां स्वस्थ हो, स्वस्थता को धारण करने वाले हो, वह स्वस्थ होता है। If we are comparing these definition, the definition given by the WHO, it is the definition of the health, swasthya, which is an abstract thing, and it is dependent on the other component like social well-being. If a person want to be healthy, he is dependent on others. What the social person, what is the other person is behaving like that, and thus this is dependent and so unachievable also, and definition is incomplete, because if you are adding a spiritual component later, then what about economic, political, and environmental component of the individual? Whereas in our Indian consent definition, the definition is given for स्वस्थ व्यक्ति के लिए दिया गया है, जो कि एक इंडिविजुअल चाहे तो अचीव कर सकता है, ये इंडिपेंडेंट है और उसको पाया जा सकता है। What is the psychosocial well-being and what is the definition of mental health regarding this? WHO again defined in 2004 that mental health is a state of well-being in which the individual realizes his own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make contribution to his or her community. And in 2015, article published in the World Psychiatry Journal where it was recommended that dynamic state of internal equilibrium, आंतरिक संतुलन जो है जोड़ने की आवश्यकता है. इस definition में this is incomplete. What is community? Wikipedia says that a community is a social unit with commonality such as common norms, common religion, common values, and custom or identity is common in the community. Whereas in other definition given in the dictionary, that a group of people living in same place are having a particular characteristics in common called as community. So what is the history of community mental health? In 1960s, US President John F. Kennedy introduced this term community mental health, and after that in 1963 he gave a community mental health centers act in his country, and in 1967 Kaplan give principles of community services, and these principles are responsibility to a defined population, treatment close to the patient's home, multidisciplinary treatment approach for the people, and continuity of care. There should be not a break in treatment, whatever individual is taking for the mental health problems. There should be a consumer participation, and services should be comprehensive in nature. And components of community mental health model, if we see, the main component is awareness generation activity. Second is promotion of positive mental health across the different section of the community. Psychoeducation to religious organizations, self-help groups, faith healers, and local bodies. As in our Indian culture, it was seen that most of the population suffering from the mental illness, first time they want to get, they used to go the faith healers for their problems, and focus on stigma reduction. Rehabilitation services is need to be established, and services which is established is easily accessible, and linkages with the primary health care and tertiary care hospitals, social welfare, and state legal services authority is required, and protection of the human rights of the mentally ill person is to be taken care of. And how can we achieve the community mental health program? By public health services and by the health promotion services, and in both services psychoeducation component and awareness component is common. Yes. And what are the impact indicators of mental health needs of the community? If there is a reduction of the treatment gap, reduction in stigma, reduction in suicide rates, reduction in death rates due to overdose of substances, reduction in violence due to mental illness and substance use, and rehabilitation of person with chronic mental illnesses, and reduction of violence in the community and schools are found, then we can say that the community mental health program is running well in our country or in any state of the our country. And what are the models which are initiated in our India for the community mental health? Basically, integration of mental health into primary health care services, and initiation and early experiences, composition of the team, treatment offered, linkages with the community. These are the component of the integration of the mental health into primary healthcare services. And second should be the services beyond hospitals, which can be available in the community. And community mental health model in India, it was initiated earlier in 1981 on the basis of two Indian studies done by Sakalwada in Karnataka and in Raipur Rani in Haryana. On the basis of the findings, the National Mental Health Program in 1982 was launched, and later district mental health program was tested in Bellary district of the Karnataka, and after after 1 year, it was implemented as a pilot project in 4 districts in 1996 to 1997. In 12th 5-year plan increased this DMSP program, district mental health program, into 123 districts of the country, and later, after revision of the DMSP and NMHP, this district mental health program and national mental health program was incorporated with the National Rural Health Mission, and now the plan is to extend it the district level in each district, DMHP in each district of the India, and by the government of India. As we are aware that in Uttar Pradesh, there are many medical colleges are being coming in the near future, and we should optimistic that the mental health care is also going to be better, and their services is going to be better in near future in Uttar Pradesh. And if we see what are the national mental health programs objectives, national mental health programs objective was to ensure the availability and accessibility of minimum mental health care for all in the near foreseeable future, particularly to the most vulnerable sections of the population, that is belonging to the poor socioeconomic status, to encourage and female and to encourage mental health knowledge and skills in general health care and social development, and to promote community participation in mental health service development, and to stimulate self-help in the community. And this program was planned to be initiated through the PSCs and CSCs. PSCs means public health centers, and community health centers. But there was a lack of coordination between these two programs. That's why the implementation and monitoring was not done properly, and the program not achieved their goal properly. Later, when it was incorporated in the district mental health program in NMSP, with the objectives that to develop and implement a decentralized training program in mental health for all categories of health personnel in a way that would be the least disruptive to ongoing general healthcare activities. Second, to provide a range of essential drugs for the management of persons with mental illnesses, and to develop a system of simple recording and reporting of care of mental health personnel. And we are using eSanjeevani portal and government portal, ERS portal, or the information, updating the information of the patient on the website. And other objectives are to monitor the effect of service of the mental health program in terms of treatment utilization and outcomes, and to reduce the stigma through public health education. Other objective is treatment and rehabilitation of patients within the community by adequate provision of medicines and strengthening the family support system. And later, DMSP was monitored by the government authorities, and in 10th, 11th, and 12th 5-year plan, there was a huge improvement in these services, and the budgetary allocation increased to the 1,319 million rupees in 2002 and 2007, between 2002 and 2007, and it was the 5 times more than 9th 5-year plan. And DMSP was extended to 110 districts, and upgradation of psychiatric wings of 71 medical colleges and general hospitals was done, and 23 mental hospitals were modernized during the 10th 5-year plan of the government. And in 11th 5-year plan, DMSP was revitalized with the provision of the following. What? There should be a program officer, a psychiatrist, and a family welfare officer in each district for the coordination of the district mental health program. There should be 10 beds for acute care. There should be essential drugs in PSCs and CSCs And also there should be more advanced drugs like lithium valproate, carbamazepine, benzodiazepines, and injection haloperidol and risperidone, etc. in district level hospitals. And training is essential for the medical officers, and establishment of 11 centers of excellence by upgradation of mental health institutions and hospitals, and setting up and strengthening 30 units each of psychiatry, clinical psychology, social worker, and psychiatric nursing in these setups. In 12th year plan, there are some principles were added for the implementation of DMSP in an effective manner, and it was the life course perspective, giving attention to the unique needs for children, adolescents, and adults. That's why RK SK program, Rashtriya Kishore Swasthya कार्यक्रम was initiated, and Rashtriya Bal Kishore कार्यक्रम was also initiated from the government. And second, recovery perspective, provisions of services across the continuum of care and empowerment of persons with mental illnesses and their caregivers, equity perspectives, accessibility of services to vulnerable groups and geographies, and evidence-based perspective. It means service provision through established guidelines and experiences only, and health system perspective, if we see that clearly defined roles and responsibility for each sector, whether it is private, whether it is government, whether it is the NGO, or the care providers, and right based perspective, ensuring the rights of persons with mental illness are protected and respected. When it was monitored later stages of the its commencement, it was found that there are limitations in DMSP program. The limitations are their poor community involvement is there, because stigma is present, and people not want to come to the mental setup or mental health clinic for the treatment, and inconsistent fund flow, and inadequate human resource and training, non-availability of crisis management and inpatient services, and non-availability of drugs in PSC and CSC level. These are the limitations of DMSP was found. And there are some lacunae also, and these lacunae are there is inefficient monitoring and evaluation of the program. There was not clarity of objectives. Hospital management information system was not adequate, and technical support for information, education, and communication is not available, and continuity of care in the community is disrupted uh, during the treatment program. But it was very good that in current scenario the DMSP program is running in 517 districts of the country. The team is psychiatrists, psychiatric nurses, psychiatric social work, clinical psychologists, and ancillary staff. It was given to the community mental health model program in DMSP, and treatment offered. I have already discussed essential drugs and brief psychosocial intervention, and for minor mental health problems is given to the community members on the health camps, etc. And linkages with the community, that is linkages with the training of auxiliary nurse midwives, accredited social health activists, and PSC level paramedical staff is envisaged during the program for the better implementation of the mental health programs. And for community mental health models in India, not only the hospital based services is required, services beyond hospitals is also required to cater the need of the population who are suffering from the mental health problems. And it can be catered to provide community outreach clinics, through community camps, through crisis resolution and home-based treatment, through self-help groups, through therapeutic community, through tele-counseling, through halfway home and daycare centers, and developing home for mentally challenged and mentally ill destitute. And of course, The program Ayushman Bharat and Ayush is also giving fund for the treatment of the mental health problems. And we have seen that in the corona pandemic, many of the telecounseling services from Indian Association of Clinical Psychologists, from IMHRC also, there was helpline available, and many helpline was available for telecounseling. And there was the telecounseling services guideline also available from the NIMHANS Bangalore. This is a publication of Snehal Gupta and Professor Rajesh Sagar, in which they narrated a review about the National Mental Health Program, and they found that the National Mental Health Program has lack of coordination between National Mental Health Program and National Rural Health Mission, NRHM, sorry, ये MH लिखा हुआ है, NRHM, National Rural Health Mission. And now the National Mental Health Program is being monitored by the Niti Aayog. Now we can expect some more monetary benefit in the mental health program. And they recommended in this paper that there is a need for regular monitoring and evaluation, and if required, mid-term correction for the proper implementation of the National Mental Health Program. In this paper, they have also mentioned that in India, at present, psychiatrist is available on per lakh population is range from 0.05 to 1.2. This is huge service delivery gap for the mental health problems. And if we see the Desai's report, NG Desai report 2004, he has given the manpower requirement for mental health in India, that one psychiatrist for per 50,000 population, one for 25,000 population for clinical psychologist, one per 25,000 population for the psychiatric social worker, and one psychiatric nurse for the 25,000 population. So thus we see that there is huge gap, and many courses are being run, and many Rehabilitation Council of India initiatives for the different kind of mental clinical psychology training programs in our country. And I have found that about more than 43 institution of the India is providing the mental health care workers training program, especially in clinical psychology, to cater the needs of the clinical psychological problems in the individual. And if we see the mental health morbidity in adolescent, it was found to be about 20%, and lifetime prevalence in adults is ranges from the 12.2% to 48.6%, and in among older adults it is 20% of our population. And the urban mental health and rural mental health initiatives was taken by the NG Desai from New Delhi, S.C. Tiwari from Lucknow, and S. Nambi from Chennai, and for the adult population. And Lucknow urban adult study was initiated by the Professor C. Tiwari. I was also have worked in this project. And in rural mental health, Lucknow rural and urban elderly project is also initiated by the Professor C. Tiwari. And we found that about 17.34% of the older person is having some or other kind of mental health problem, and it was more common in lower socioeconomic status and in female population. And in rural population, the prevalence was quite higher, in about 23.7% among the older adults, where mood disorders is more common, and 2.8% dementia was found in the rural community of the Lucknow population. Yes, without talking about the suicide, if we're talking about the community mental health, it is not justice to the topic. So here, this is the screen of the Professor Sarbjit Singh, who is a professor in Agriculture Institute of the Punjab, and he given a model, multifactorial etiology of farmer suicide, where he gave 7 Ds. That the reason is death, depression, death, disputes, diseases, drugs, and disrepute is the reason for etiology of the farmer suicide. And he also claimed that there are 7 R's which can be preventive and protective factors to the suicide of the farmers. And these are the remunerative agriculture, resilience building, reassurance through connectedness, righteous conduct, religious support, responsible reporting, and rational expenditure by the farmers. Okay, these are the current study that depression is prevalent in 25% in community in COVID-19 period, PTSD, and anxiety is prevalent almost 28% in PTSD and 21% to anxiety and 30% depression. And new policies and act is also um, introduced in the current scenario, that uh, National Medical Council, which was earlier MCI, Medical Council of India. So they are approaching to the new medical colleges and private hospitals to give the recognition if they are completing their norms. And new education policy is also initiated, and here the focus is for skilled based training. Rehabilitation Council of India is running 34 institutions for MPhil in clinical psychology program, and many are in row for recognition. And Mental Health Care Act in 2017 was launched to deal with those problems which was not taken care of in previous Mental Health Act. And central and state mental health authorities are being also uh, in a row for their commencement. And in recent development is the National Commission for Allied and Healthcare Professional Act in 2021, in which behavioral health science professionals can be recognized, and where the psychologist is the major part of it. The psychologist, behavioral analyst, and healthcare educators, and also the clinical psychologist is still is governed by the Rehabilitation Council of India. But this step can provide us more mental health professional to cater the need of the community problems. And WHO says that there is 4 A's for the implementation of the health promotion, and 4 A's are availability, accessibility, affordability, and acceptability of the health services in any sector. And in my opinion, there should be one more A, that is appreciability. If we cannot provide the service which can be appreciated by the people, the service is not going to see its success dawn. And Ayushman Bharat Health Infrastructure Mission is launched before 5 days. And yes, and today in G20 summit, One Earth and One Health slogan was given by our Honorable Prime Minister Narendra Modi ji to cater the need of the community health as well as mental health program. In my way, the way forward for the community mental health is the revising the definition of health and mental health is required, so that everybody can be healthy. In inculcating the socio-cultural aspect of each individuals, and emphasis on lifestyle changes, as Professor Mehdi sir described earlier in his lecture. And awareness generation activity is required in each level. Indigenous concepts like ancient Indian thought. He also recommended about the pranayam. I also recommend doing yoga and reading Srimad Bhagavad Gita concept and practicing. It is very good to maintain our psychosocial well-being and mental health. And use of vernacular language in teaching and training. हम जिस भाषा में सीखते हैं, जिस मातृभाषा में सीखते हैं, हम कम मेहनत में सीखते हैं, अच्छे से सीखते हैं, बेहतर से सीखते हैं और अच्छे से सोच पाते हैं और अच्छे से आगे बढ़ पाते हैं उस चीज को लेकर के। तो ये जरूरी है। एंड टू फिल गैप्स इन सर्विसेज, I have earlier discussed, and I think that charity begins at home, and thus we used to start healthy thinking, healthy behaving, and healthy expressing to care of our mental health as well as other mental health. And judicious use for newer technology, print, electronic, and social media for awareness generation activities required, and thus we in future will be able to cater the needs of the community mental health program. There are the many helplines for the mental health program uh, services. And yes, e-Sanjeevani portal is also is being initiated in COVID-19 period, and successfully everyone who is digitalized, who is using a smartphone, and if not using, you can cyber cafe you can use, and from there you can take consultation of your problems from home. And I acknowledge all gurus, parents, friends, the Reputation Council of India, IMHRC, our e-library, and COVID-19 also, because we are interacting with this forum, Zoom meeting forum, due to COVID-19. Otherwise, we have met in personal in the conferences. Thank you. These are my reference texts.